And so it's official. So officially welcome to Open Forum, September 15th. Today we're talking about adverse childhood events and its effect on late life cognition. And just a little bit of introduction, we're going to do a lot of definition work today. And my goal is that at some point in time in the lecture, your brain goes, oh, I just put that together. That makes sense. Now I understand what she's talking about. So the reason that I chose this topic is, one, it's a passion of mine to learn more about how our cognition is affected. As an integrative neurologic provider, what I see a lot in my practice is that conventional neurologists will actually refer me patients once they have some sort of cognitive decline, saying, we don't have anything left. We've got some patches, we've got some pills, we've got a memory care facility. If you've got anything over there, doc, do your best. And so in the assessment and the evaluation of these people who come to me with either mild cognitive impairment, the early signs of Alzheimer's disease, whether it's Parkinson's disease or just stress-related cognitive decline, I feel like my job is really less like a physician and more like a detective. Is there anything else within the physiology, anatomy, mental health, structural capability, perfusion, cardiovascular health, you name it, that's affecting your brain from being able to remember? And now being 4 years into clinical practice, the thing that pops up for me the most is trauma. Is that so many people who come scared out of their mind that they're experiencing some sort of memory loss, when we really dive into their labs and their blood work and the imaging and their medication efficacy, nutrient deficiency, what comes up over and over and over again is trauma. And so we, if anybody has, met me in a clinical setting, I'm a scientist by nature. So in medical school, the first year we do a lot of philosophy. What are humans? How do they orient to disease? How do they relate to the world? How do we create good therapeutic alliance with our patients? And I kind of, in the back of my mind, was like, yada, 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 get to the good stuff. Teach me the drugs and the herbs and how do we treat and heal and fix people, right? Like you want to go be a doctor. You want to do these things. And the humility that has come in practice is really that so many of those things on a superficial layer only matter or are effective for my patients if their body is in a safe space to be able to receive treatment, to receive care, to receive healing. And so many of my patients are not there. And so reverting back to the research and experiencing more with the biofeedback and getting a certification in that, what I have learned is that we really need to be addressing this while we treat the cognitive decline, enhance the activities of daily living and quality of life, but understanding why our brain is working the way that it is. So again, over and over and over again, it's this trauma-informed cognitive decline. That being said, you go on PubMed and you type in adverse childhood events and cognitive decline, and you are bombarded with research articles. And I just want to share, I'm not going to get into the science today in a way that's going to be overwhelming for anybody, but I really want to show you just on a quick search what is popping up for us when I did do this. So that's not the screen I wanted. And we're going to go through this definition, but over here is my getting on Google Scholar, ACES and Cognition, and you can scroll down and see, at least 10 pages of these research articles that are exploring how does the amygdala affect emotional memory. We got another one over here. Stress, memory, and the amygdala. And there that is. Explicit memory and implicit memory. We've got up here, beyond emotion, understanding the amygdala's role in memory. And I'm going to go through some of these definitions. But really my point that I'm making here is the research is now there. And where before, I think we were all hypothesizing that, hey, this has something to do with our health. And there's a great YouTube video that I assign a lot of my patients who have adverse childhood events by Dr. Nadine Burke-Harris. And she says it so clearly and poignantly. And I linked it in one of these presentations in the chat box, and I'll be willing to share it with anybody who emails in as well. But really her talk is for physicians, for clinicians, saying, if we're screening people for heart disease, for smoking and sedentariness and family history of heart disease, and we know that adverse childhood experiences are related to inflammatory conditions later in life, then the physician level practitioners are doing a disservice to our patients and to our community by not screening for these things, because we know it's a major risk factor. And in my opinion, and in my practice, it's the biggest one, because again, as we're going to get to, it's how you orient to the world. How does your nervous system orient? How are you responding? What are your mechanisms of coping with distress? And how do we shift and change that so then you're able to receive care and treatment and actually enhance neuroplasticity in a different way? So we're going to go into a little bit of definition work here, because I'm going to be talking about a lot of neuro words, and I want to make sure that you understand what they mean. If you're on here live, I'm going to run through them, go back and listen to the recording, slow it down, pause, take definitions if you need to. But we're going to kind of run through there. So this website, I love acesaware.org. This informs my screening protocol in my practice. There is 10 known adverse childhood events. Of course, there's subcategories for all, but when you're looking at an ACES score for a person, it's one of deprivation. Did you feel you didn't have enough to eat, had to wear dirty clothes, or no one was there to protect, take care of? And I always add in my practice, or love you. Did you feel unloved? Did you lose a parent through divorce, abandonment, death, or other reason? Did you live with anyone who is depressed, mentally ill, or attempted suicide? Did you live with anyone who had a problem with drinking or drugs, including prescriptions? Did your parents or adults in your home ever hit, punch, beat, or threaten to harm each other? I also add into that throwing. Breaking, destruction is also a form of violence in the home. Did you live with anyone who went to jail or prison? Did a parent or adult in your home ever swear at you, insult you, or put you down? Did a parent or adult in your home ever hit, beat, kick, or physically hurt you in any way? Again, I add throw to that. Getting things thrown at you is also violence. Did you feel that no one in your family loved you or thought you were special? And did you experience unwanted sexual contact? And so when you add these numbers up, you get a point for each one that's positive, and then we give you an ACES score. What I have noticed in my clinical practice is it doesn't matter if you had a 0.5. It is going to impact your orientation to the world and what safety is. And I'm going to get to that here in a moment. And so this is a screening tool. It's very similar to anybody who's do you have thyroid disease? Are you constipated? Do you have dry skin? Do you have loss of hair? Are you cold in a warm room? Right? We know the screening checklist for so many other health conditions, yet we neglect to screen people for these adverse childhood events. So we'll stop sharing here. And then I'm going to talk a little bit more here about a couple more definitions. So here I want to orient you to the brain. Again, this is very surface level. I'm not going to dive too far into, neurology 101, but I want you to be very clear that the amygdala, the little almond-shaped place in your brain that's in the temporal lobe, is responsible for forming memories. It is implicit memory specifically. And what implicit memories means is, what is the emotion attached to the memory? Initially, we kind of assumed that this was always a negative emotion. We're only going to remember these emotions that are attached to a memory that have a negative emotion, but really it records the positive ones too, right? You made the winning kick for your football game. Something big that happened to your life that had emotion attached to it. For the purposes of this lecture, we're going to talk about the negative emotions associated with memory, because these implicit memories begin before we have declarative memory, before we're utilizing that temporal lobe and prefrontal cortex to make logic and reason out of our memories and understand that we're trying to recall them. We have this amygdala activity all the way from birth. I'm hungry, I'm screaming. That's fear. Ooh, I remember I got fed when I screamed. I'm going to do that again, right? Anybody who has kids now, ooh, she gave me broccoli. I don't like broccoli. I'm going to scream again until I get a cookie, right? Ooh, that worked. If I just keep screaming, I get more cookies. But this is how we then store, okay, this is what works. This goes into a different segment of the brain, more in the temporal lobe. This is where we're going to process and store our memories. But the amygdala is really there to help keep us alive, keep us safe, for survival. The amygdala memories are not there for thriving. They are not long-term. When we go to sleep, the amygdala starts the processing or consolidation of memories. But then when we sleep, we send those memories to their appropriate places in the brain to be stored for later recall. Now, the amygdala does have the interaction with the hippocampus and the prefrontal cortex, like I just mentioned, because it does play a part in the stress-induced impairment of memory retrieval and working memory. Working memory is that executive function. We're not going to lose track of what we're doing once we start a task. So we trigger the amygdala. We have fear or a threat detection. We initiate the flight or fight response, whether that's screaming, whether that's throwing a tantrum, whether that's running away. We have the flight, freeze, and fawn, whether we blend in, we just not move, maybe we're not here. And then we take that memory, and again, we consolidate it that has a strong emotional component. We activate our stress-activated neurotransmitters, our cortisol, our norepinephrine, our epinephrine, our noradrenaline, and we create something that this is really important, neuroplasticity in the brain regions. So when we hit this fear mechanism, what we're doing is saying, remember this, practice it, know what's going to happen, and then you can start to anticipate it next time. Take all of the information that you've been given and then train your brain how to recognize it next time. So I'm going to take a pause from the nerd for a second, and I'm going to tell you a story, and we're going to come back to this with some other definitions. And if you've ever been a patient of mine, you've heard this story at least once, but it's the snake and the stick, right? If you're 2, 3 years old, you're walking along a wooded path and you're with your parents and they're arguing and it's fall time and the leaves are crunching under your feet and it smells like fall in the air and you see a poisonous snake and you're totting around and you don't know what's going on and you reach down to touch it and your mom screams and everybody throws this huge, oh my God, you're in danger. And she sweeps you up and you're taken away and you're crying. And it's this whole scenario that you were in danger and your amygdala is like on it. Everybody's heart's racing, you're sweating, you're screaming, you're in complete fight or flight mode, right? The 50, 60, 70 years later, you could be walking down a wooded path in the fall time, a half a country away, have no active recollection of this memory because 2 or 3, we don't have active memory retrieval then. No one's ever told you you've ever seen a snake before. And you're walking down this wooded path with your spouse and you see a stick and you jump and you're like, and your whole body goes into this like panic mode. Your heart's racing, you're sweating, you're nauseous. Maybe you pass out, whatever your response is, it's this huge, irrational, disproportionate response to a stick. And everybody has had one before, and thank goodness for it. Sometimes we don't know why, but we can be like, whew, something was funky there. But the point I'm trying to make is when we see the snake, our amygdala doesn't just take a high-res picture of the snake, right? It takes a panoramic picture of the entire scenario. What season was it? What did it smell like? What did you hear? Was it the crunching leaves? Was it the tone of the voice? What led you up to see the stick? What color was the snake? What color was it? And it takes this giant panoramic picture of it and it says, hey, you need to know this to survive. And so without doing further discernment and further work on whether snakes are safe or not, we're going to be scared of all snakes anyway. And then we're going to jump at sticks when all of the conditions are met appropriately. Now, knowing that to be true, I'm going to take you into another definition. And I'm going to share my screen again. PowerPoint. Here it is. So the next definition I want you to be aware of is called neuroception. And neuroception is the process through which the nervous system evaluates risk without requiring awareness. Neuroception is what's happening in our body 24/7, even when we're infants, even when we're asleep. So if you are aware in sleep studies or in sleep research, we know that we wake up multiple times on a subconscious level. And the reason that we do is to assess our environment. Are we safe? We safe? We good? We know where we are? Cool, I'm going to go back to sleep. Infants, when they wake up, they're often not in your arms anymore. They're not in the bassinet anymore. They're not in a place that they recognize. So they wake up in the middle of the night and they cry. I don't know where I am. I don't feel safe. It's dark. All the way up into toddlerhood, sometimes even younger children. And so this neuroception goes on 24/7. And if you're not exhausted already by me telling you this is happening, you should be, because 24/7, our body is sending out this radar to assess our environment. And it's trying to discern between cues of safety, danger, and life threat. When we do experience the feedback, then we shift it to optimize your survival, which is interoception. How do we translate the information that we're getting from our ship's radar into actual response time? A lot of times people will talk about this as if it's your gut feeling or your intuition. And, the example I like to use all the time is, I used to fly jets for a living for the United States Navy. So with all the money they invested in me, all the money they invested into the planes, the mission training, the entire operation, what they will do is they will say, you'll brief an entire flight, you'll debrief an entire flight, and then you'll go into the next one. And they'll go, you know what? If it feels off, quit. Stop the flight. And the words that we always use was knock it off. And I really love knock it off as an internal dialogue between yourself too. And we'll get to having an internal dialogue a little bit later. But that knock it off is really that, hey, something doesn't feel right. And the United States government knew that even with all this training and the best machines on the planet, that if a pilot or an aviator was like, something feels wrong, they know that's a risk factor for a mishap. So when we go to say, is it just gut intuition or am I being malinformed? It can lead to misinformation when there's layers of trauma, but really when everything's operating correctly, that's the amygdala doing its job in resonance with the rest of our body. Hey, I'm sensing something's off. I think you need to be more aware. And those are when we say, hey, trust your gut, trust your heart, know what you're doing here, because it's going to be really important. But again, down there, the caveat is it's not always accurate. So we go back to the snake and the stick picture. This is a panoramic picture. This isn't a high resolution of just the snake, right? So now we have this radar that's going on nonstop, this neuroception under the surface saying, am I safe or am I not? And in the grand ocean of the environment that we could have, we have pirate ships and we have canoes. But what happens when we layer that trauma, panorama over panorama over panorama over panorama? Now we have an ACES score of 4. And then we have some adulthood trauma in there. And I'm not even saying negative trauma like abuse or loss or grief. I'm saying having a child, getting married. These are traumatic events by definition because they change our orientation to the world. They change how we relate. They change how we exist. They change how we view things. And so we start layering up all these panoramas. Now you can imagine that your radar is getting a little bit saturated and it's going to have a really hard time knowing if it's a pirate ship or a canoe. So what do you think we do every single time we see a blip? Boom, fight or flight. Boom, fight or flight. Right? We're just reacting all the time. And what I tell folks is if you were reacting all of the time, you are going to be really, really good at the professions of firefighter, physician, military people, ER. So, I mean, even at your job, if you're outperforming everybody at your job, even if it's in manufacturing or at a desk job, and you're just like, I'm on it all the time. Where's everybody else? They're moving slow as molasses. I have 3 situations and answers already queued up for a situation that didn't even happen yet. Then I hate to break it to you, is you're not that great at your job. You're hypervigilant. Your body is operating in the mode where you're always ready for threat because everything in your environment is one. And so when we start to understand more about how that radar works and our inability to discern threat from a canoe or just a blip or just it's fall time and I saw a stick and I'm not in danger, now we get to recognize, just like that bottom bullet point, saying it's not always accurate. In a maladaptive state under conditions of trauma and chronic stress, we lead to growth and genesis in the amygdala. And the part of our brain that's supposed to recognize fear and put us into the fight or flight mode, this one gets bigger. I'm going to pause here because I've been saying a lot. Does anybody have any questions up until this point in time? And you can use the chat box. You can unmute yourself. This really is kind of a free-for-all as far as that's concerned. Everybody's tracking along so far? Okay. So now I want to shift a little bit into just some more anatomy. And we're going to talk about the seahorse. So the seahorse is the hippocampus, right? And they named it the seahorse because it looks like a seahorse in the brain and it wraps around that temporal lobe. And it's internal to there, it attaches to the frontal lobe, the thalamus, and it attaches to the amygdala. It's part of our limbic system, our emotional response system. The really cool thing about the hippocampus that I don't think many people know is it continually reproduces. Its cells are turning over at a regular rate. So when we talk about cognitive impairment and temporal lobe atrophy and things like that, my question that I don't believe has been answered yet is, where are we missing the cue to help those cells turn over, right? We know that it does it. When does it start to atrophy? That's just a question I'm going to throw out there. It's rhetorical. But really, in a study, what we did is we based prediction on how well participants recalled items based on hippocampal activity during the learning. And what they did is they stimulated the hippocampus while they were learning something new in one group. They did not in the other group. The one who had stimulated hippocampal stimulation were actually recalling the information better than those who didn't. Seems really simple, right? But it's not, because how many of us don't multitask? How many of us are actually activating our hippocampus when we go say, oh, hey, Bob, nice to meet you. My name's Karen. And then we walk away and we go to, who was that again? What was her name? Right? How many of us are actively engaged in stimulating our hippocampus when we're learning something? Or are we looking over our shoulder for the next thing? Or when we're listening to somebody speak, we're preparing what we're going to say next. Well, I think this is what's coming. This is what I'm going to say next. Here's what I know. Here's what I'm going to say. I mean, we are not a listening society anymore. We're very much, I'm going to prepare for what I'm going to say next. And here's what I know. So the big takeaway from here when I'm working with people with memory impairment is, can we do focus and attention work so that you can actually start stimulating the part of your brain that's responsible for recalling the information later? It's like, I joke with my husband all the time. He goes, where are my keys? Where's my wallet? Where's, I'm married. So I get that everybody who's married has been in this situation before. And my answer to him is, it's where it goes. Where are my keys? Well, they're where they go. It is no fun being married to somebody who does memory work, by the way. And he goes, I don't know where it goes. I said, well, then that's the main problem, right? There's the root of the problem. If you don't know where they're supposed to be, then you don't know where you're putting them. And although it's, a joke and jest in nature, it's how we need to treat all of our memories. If we don't know where they go, then we don't know how to retrieve them later. And we're not going to be able to, because we threw our keys in the bucket, or we put our keys in the freezer, or we set them by the door. And so when we start to consolidate those memories and send them to where they need to go during sleep, really quick adjunct, which shouldn't be really quick, but hey, number one question for anybody with memory impairment is, are you sleeping? Not only do we know that we consolidate and process memories during our sleep, we also know that this brilliant situation called the lymphatic system is happening when we sleep, and that's flushing the toilet of our brain. Our lymphatic system in our periphery happens all the time, and it works with our circulatory system. But those lymphatic vessels in our brain, which remove toxins and debris and oxidative stress molecules and particles, that only flushes out when we're in deep sleep. So if you're not sleeping, you're not going to remember the end, check box, work on sleep. But it's more complex than that. So again, we're not just remembering facts, we're remembering the emotions. And if the emotion trumps the fact, if the emotion of seeing the snake trumps the fact that actually you were safe and it was fall time, and fall time's not the scary part, then you're not going to remember anything else. You're going to remember the fear and the emotion behind that. And that's what's going to come back up when you see the stick. So making sure I'm getting all of my things that I wanted to say. So the emotionally salient memories is going to tag that memory for survival. Another really cool study that they did is they had a control group. They had a group of people who had temporal lobe lesions, and they had a group of people who had amygdala lobe lesions. And they showed all three of these groups a sequence of color blocks. Red, orange, yellow, green, blue, purple. Let's just say it went down the rainbow because I don't actually remember which order it was. But every time it hit blue, they would press a really, really annoying sound. I think it was a ship's horn. And would come every time they showed blue. And they did this over and over and over and over again. And then they paused it. And then the next time they ran through the sequence of colors, they asked the people with the hippocampal or the amygdala activity, they said, hey, what color was showing up when the horn blew? And the amygdala memory people every single time said blue. And then they said, which color came next? I don't know. Right? No idea of what logic part was coming. They just knew every time that horn blew, they were irritated. They had an emotional reaction. So they knew which color it was. They asked the people with the temporal lobe lesions, what color came after blue? Purple. I think I have this backwards. Reverse the groups. So the amygdalar lesion people, the ones who didn't have the lesion, were able to say purple came after blue. The ones who had the temporal lobe lesions were not able to tell you which color came next, but their amygdalas were working, so they were able to tell you which color popped up when the horn sounded. So hopefully that makes sense. I can say it again, but it's really where the lesion was, that part was not activated. So the temporal lobe folks couldn't make that fact part come out. Purple came next, but their amygdala was working, so they were able to tell you blue was when the horn blew. So it was really fascinating to see where, again, those memories are stored and how we put them there. There has been over 266 publications from the years of 2008 to 2020 to talk about the 4 major ACEs, adverse childhood experience, physical, sexual, verbal, and low socioeconomic status or deprivation, and its associations with impaired cognition and attention in older adults. So this is no longer a counseling session with me and my patients. This is no longer talk therapy. This is no longer, hey, I suggest that we maybe dig into this a little bit more. This is, hey, this is a risk factor for your memory. This is what's happening under the surface. And unless it's addressed, there's not going to be a pill or a supplement or less booze or an exercise that's going to trump this. And the reason is when your amygdala is activated to keep you alive, ain't nothing that's going to out arm wrestle it, right? Nothing. You are in this mode to say, I'm fighting for my life. And there's going to be, you just can't out arm wrestle that. You're not going to logic and reason your way out of it. And I use this phraseology so much with my patients because what I see the most is I'll have a patient and I'll say, let's talk about your childhood. Tell me a little bit about your story. And they'll go, childhood was fine. I had a good childhood. It was fine. Okay, look, tell me a little more. Did your parents stay together? What's happening? How did you get along with your siblings? Fun fact, sibling violence is the last known and researched form of physical and domestic violence in the medical field. And it is very, very important to acknowledge because that sibling relationship is not much different than the parental one. And in my opinion, sometimes even more harmful because they're not your parents, right? They're not supposed to be authoritative. So if they're abusive, it's really coming from this place of you're supposed to give me unconditional love and kind of be my best friend and be my family, and you're abusive. So that loss of trust there is compounded because if your siblings are abusive and your parents aren't stepping in, now we have abuse and neglect. So again, a side note there. So that, we dive in, but it was fine. My dad had a really tough childhood. My grandpa was in the war and he didn't talk much. He didn't know how to show emotion. He drank a lot. So my dad had it really rough. So it's good. It's good. I say, I'm not here to villainize anybody's parents. I really am not. However, your 7-year-old brain did not have the capacity with its neurodevelopment stage to logic and reason your way out of fear. It didn't have the ability to logic and reason its way out of neglect, and it didn't have its ability to logic and reason its way out of deprivation, right? I had a single mom. She worked 3 jobs. She worked really hard for us, and I so appreciate her, and she's my hero. Oh my gosh, that's great. I love it. Deprivation is still a risk factor for chronic inflammatory diseases, not having enough. It doesn't mean anybody's doing anything wrong in that situation. It just is. People who are born with a family history of heart disease didn't do anything to deserve that either. So we're talking this layer of ancestral trauma that's probably going to be another lecture another time ago, but remembering and recognizing that we cannot logic and reason our way out of something that was built in before we turned about 25, when our full neurodevelopment has completed. I like to joke for women and maybe a little bit later for men, but in that time frame, we get that full neurodevelopment and the ability to logic and reason and reflect and be self-aware, and we're not as narcissistic as we were when we were kids. So finding your way through those patterns only works if you acknowledge the patterns were there to begin with. And there's a term for that, and it's called reappraisal. Can we alter or update how we think or frame an event to change the impact, which makes us adaptive, which leads to resiliency? When we're in an expressive suppression, which is the other term or the opposite, we're actually consciously concealing or inhibiting emotional expressions, which leads to increased fatigue, lower self-esteem, and more psychopathologies, which is diagnoses, of mental illness. And it's just without the awareness of this had happened and what my neurodevelopment state was at while it did, we cannot heal, we cannot reframe, we cannot reappraise that event, which means we're not going to ever move through it in a way that says we can reorient to the world as being safe. So what do we do, Doc, when we don't even have any conscious memory of the snake? I don't know why I'm acting the way I'm acting. I don't know why I have a panic attack at random times, a couple times a week for the last 3 years. I don't know what's happening. I had a patient who had a sexual assault 3 separate times in her life, 3 separate times, different people, different events, different situations, going through the EMDR, going through the therapy, going through the trauma work, having these panic attacks at random, various intermittent times in her life. I have no idea what's happening with me. I don't know what my cues are. I don't know what my triggers are. And in working together and working with counseling and working with all kinds of modalities, can you imagine what came out of that panoramic overlay of her trauma? Anybody want to guess who doesn't know the answer already? Blue paint on the wall in her environment was the common denominator for every assault. And so you go to a hospital, you go out to lunch, you go in a bedroom, anywhere you go. This is the trigger in her subconscious that says, hey, you've had enough things line up here. I don't think you're safe. You need to go. Had nothing to do with the actual event. What is your environment? What are those triggers? And you can do the work. There's so many different modalities out there doing this kind of work. Lifespan integration counseling, journaling. There's just a lot out there. Again, you can reach out to me for that type of thing, but it exists. The ability to record, reflect, and improve self-awareness to understand what your triggers are, change those panoramic pictures, take them out of the amygdala filing cabinet, reassign them to a temporal lobe one where you're like, I can recall this when I want. I know what happened. I understand where the threat was. And now I can understand where I'm safe is going to be imperative to the healing process for anybody. And now we're talking about cognition. So one of the most important facts that I came to know, and this is a couple of years into my practice, and I just kept saying, you cannot arm wrestle your amygdala. And I was, on record over and over and over again saying, we need to do breath work and you need to do grounding exercises. And one of my favorite metaphors is when the wheel is spinning, where do we throw the stick in, right? Like, where do we stop it? There's got to be a point where we can just stop it, that intrusive thought, that panic, that fight or flight response, and telling somebody, you can't consciously arm wrestle your amygdala and then saying, but here's how we have to do it is, a little bit hypocritical, right? Like, I'm not giving any answers. So what I noted in my research is that when we express curiosity, pure curiosity, we trigger our hippocampus. We release dopamine and we trigger our hippocampus, which, if you remember from earlier, is the part that's activated when we try to learn. And it's the one that we activate when we're trying to recall. And so when we express curiosity, we're actually firing up that part of our brain to say, I'm truly curious. Can I release dopamine, which is our hope neurotransmitter, right? Which is that kind of hope reward. It's a feel-good neurotransmitter. And we're lighting up our temporal lobe. So instead of trying to arm wrestle our amygdala or our fear of threat using our prefrontal cortex, okay, if I can just logic and reason like, I'm not in danger here. I'm not in danger, right? And your amygdala is going, yes, you are. And I'm always going to win. That battle's never going to happen. If we express curiosity by asking a question, we actually can, instead of arm wrestling it, just light up a different part of our lobe, which will naturally inhibit part of that fear response and then allow you to potentially transition into the answering of the question or just sit in curiosity, which was the space that we want to be. So using the example of the snake and the stick, I'm having this really big response right now. I don't know what's happening. I'm feeling triggered. What's happening right here? Instead of saying, I'm safe, this is ridiculous, get your shit together, what's going on? Like, trying to arm wrestle that fear. What if I said, is this a snake or a stick? And I was genuinely curious about my environment and my surroundings. Just by asking the question and instead of trying to convince, I'm using a different part of my brain. And that can break the cycle. And I cannot tell you how many patients I've had with chronic anxiety, severe debilitating anxiety, tell me that one question has shifted their ability to reorient in the moment of panic and anxiety. Asking the question, being genuinely curious instead of trying to fight the fear. and the threat that's there. So that was the kind of the missing piece for me that said, oh, this is the part we need to start implementing, is what's the bridge? How do we get to the place that, okay, now we go into our grounding exercises. And believe it or not, if anybody here is an athlete, right? I used to play basketball. You don't just practice free throws when the game's on the line, right? You're not just like, okay, I'm MJ, I'm going to win this game. Nothing's coming my way. I've got this. Because all the pressure's on, I'm going to make my free throws. You practice when you're calm, you practice, you shoot, you're over and over and over and over again. That repetition is the neuroplasticity. We talk about muscle memory in athletics. I'm talking about neuroplasticity in existence. How do we train our brains to recognize safety? And in adverse childhood events, when they've never known it, right? This isn't just, hey, you need to go meditate for 20 minutes twice a day because you got too much going on. Right now in my life, that would be really helpful. Meditation 20 minutes twice a day would be extremely helpful for the pace of my current life. I know what safety is. I've experienced safety. I've done the work to introduce this and retrain my brain what safety is. So now utilizing that space in a therapeutic way is really important. But all this self-care stuff that they're throwing at you, need to do this and you need to do this and you need to change this, to somebody who's had an adverse childhood event, it's actually more unfamiliar and scary than being unsafe. I only know how to feel unsafe. I don't know. I only know how to fight or flight. This is all I know. So when you tell me to slow down and breathe and meditate and sit still, that's really uncomfortable and it can elicit more anxiety. So especially in the moment of distress, right? Where the game's on the line and you're like, I've never shot a free throw before, so I'm going to, shoot it between my legs, like in the Hoosiers movie. Like that doesn't happen. Hardly, probably. But when we practice these grounding mechanisms, whatever they are for you, and I'm going to give you an example of a couple, in calm, in short spurts, and really are more aware and do a lot more of the work, we actually can start to retrain our brain. I precepted with this phenomenal neurologist back at the Center for Healing Neurology, Eileen Ruhoy, and she's just miraculous at how she explained the brain to her patients. And I've stolen so many of her metaphors, and I try to always give her credit. But the most important one to me was that neuroplasticity, think of it as trying to pave a way through the jungle, right? Your very first time through the jungle is going to be slow. It's going to be challenging. You're going to be pulling at weeds and plants and sticks, and things are going to come out and bite you, and you're going to get whapped in the face with a tree branch. And it's slow moving the very first time. And the second time, maybe you grab a machete and you're like, okay, some of the big stuff, we can get down. And then the third time we're going in with like a weed whacker. And then the fourth time we go in with the lawnmower. And then we go in with some gravel. And then we go in with some concrete, right? And this takes time. And the older you are with adverse childhood events, the longer you've been preparing a road the other direction, right? That road is like the freeway. Zoop, we're going right down there. Here's our familiar responses. So doing the work to pave a new road takes a lot of time and intention. And the difficult part is, I just had a conversation about this with somebody yesterday, is that this road never goes away. It's not that the jungle's ever going to grow back over it. We don't just process through trauma and say, that chapter is closed, we're done, right? And again, there's a part of us when we do work through it and we do retrain our brain, and then we recognize those triggers and we catch them head on, and we're like, yo, I see you. Here's what I'm going to do. Here's my mechanisms. I got this. And you make your way through your first response that's on this road. You're actually going to be kind of grateful for that road, right? Because it's the road that got you here in the first place. If you didn't have a survival road, then you wouldn't have made it through your trauma. But it has to be an intentional choice to take that fork in the road to the one that's less familiar. And if you're 40 years old or older, this new road is always going to be less familiar than the old one, just by nature of age, time traveled, how frequently we use it, how much trauma you've had. So the road's going to be there. We can't put up a block. We can't shut it down. We can't grow the jungle over it. So the word here is we have to intentionally choose the other one. And we can't do it when we're in distress. So we really have to find those times to elicit the breath work, to challenge our vagus nerve, to set our nervous system into, we really want to learn what safety is. Because the beautiful thing about human physiology is that if you've never known that you weren't safe cognitively, then you're just going to adjust. This is my norm. Hey, my name is Karin and I operate at this speed all the time, and that's fine. I'm not stressed. I'm not stressed. You're stressed. I handle things. This doesn't even phase it. I've seen worse. How many times have I heard that? I'm not stressed. I've seen so much worse. That doesn't mean you're not stressed. It doesn't mean that your body is not under duress. It doesn't mean that you're not releasing cortisol. It doesn't mean that you're operating. Do you have high blood pressure? Right? Oh, yeah. How many people in my cognitive impairment group have high blood pressure too? Are you working on super speed all of the time? And have you become so used to it that we can't press the brake? So the next point I want to make, and we're kind of moving into the end here, is that pressing the brake. What does that look like? You're driving down the road, you see a yellow light, and it's getting ready to turn red. Who just comes to a stop by releasing the gas? I really hope none of you call the cops, right? It just doesn't work that way. In order to stop, we have to take an action. We have to be intentional, and we have to push the brake. In order to rest and be safe, we have to intentionally seek that space out for ourselves, especially with adverse childhood events. So what does that mean? Quick anatomy lesson: the vagus nerve, the 10th cranial nerve, Latin for the wandering nerve, goes all the way from our brainstem all the way down through our anus. It's responsible for that visceral response, that interoception that I talked about, receiving messages from our viscera, sending it up to the brain, and then bringing back from the brain what we need to do as a result. The vagus nerve, when stimulated intentionally, it is triggered, it is activated, use whatever word you want, puts us into the parasympathetic nervous tone: rest, digest, restore, and heal. When it's not activated or stimulated, we go into our passive state of being, which is with our breath. Every inhale, we go a little sympathetic, which is a little heightened, and every exhale, we go parasympathetic. Our body is homeostatic. It wants to find a balance. But when it's activated, stimulated, triggered, we actually go into the parasympathetic nervous system. The quickest, easiest hijack to stimulate your parasympathetic nerve is with an exhale. Hey, Karin, what's the answer to that question that you asked 5 minutes ago on the test, and you have 3 seconds to answer it? What do? Breathe in, my shoulders goes up, my anus sphinx, everything is, I don't know, my heart starts racing, I start sweating, I'm in fight or flight, right? I'm not running from a bear, but my body is. Now, when do we let go? How many times in our life do we go, I'm just going to exhale. We're breathing up here. You can see my breath. You can see my muscles. You can see my shoulders. You can hear how shallow it is. This is how we breathe. Most of us hyperventilate. When I take the respiration rate of my patients, it averages between 15 and 20 breaths a minute. Coherence, resonance between your heart and your breath and your heart rate variability is between 4 and 7 breaths a minute. It's 1 breath every 15 seconds. How many of you are doing that? I mean, none. I can answer that question for you because I don't ever see it. We're all hyperventilating. We're only breathing into the upper lobes. We're not even breathing into our diaphragm. We're not even getting to the point where our heart rate can be variable because it's just stuck here all the time. We got to go, 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 go. So metaphor time again. You're jumping on a trampoline just by existing. You're going to tell me, Karin, you can't take away the situation I'm in. I have to go. I have to do this. I get it. I'm a mom of a toddler. I'm a physician. My husband travels for a living. I get it. You got to go. You got to do the things. You have to adult. You have to function. You have to remember. But you don't have to do it without pause. And if you want to argue with me on that, we'll do it offline, because you do not have to do it without pause. And an intentional pause with your breath work will retrain your brain what safety looks like. And it's one of my favorite metaphors to use because most everybody's been on a giant trampoline and you're jumping all day long. And if you never step off that trampoline, by the end of the day, you're going to be really high in the air and you're going to be exhausted. So when you go to bed, you're going to crash. And you're talking to an aviator here. A crash landing is not the same as a controlled landing. Yeah, you're both on the ground. One's safe, one's not, right? So you crash because you're exhausted. And then you sleep. Maybe you wake up at 2 a.m. because your cortisol is still like trying to come down from the ethers going, wait, are we safe? Do we know what's going on? Did you finish that to-do list from today? What do you have to do tomorrow? What time does Jimmy have to get to soccer practice? I could have swore I forgot this, right? It never gets a break. So we're not really rested when we wake up in the morning, even though we think we've been sleeping for 6 to 8 hours, and then we go do it all again. So if we were to step off the trampoline every hour of your waking time and take 3 to 5 breaths, not minutes of breathing, 3 to 5 breaths at a controlled pace with an exhale longer than an inhale, and lower your shoulders in through your nose, out through your mouth, ballooning into your diaphragm 3 to 5 times, you're actually stepping off the trampoline. You're resetting your nervous system, and then you get to start bouncing again. So yeah, you're bouncing all day long. You're going to go, but you got a break. You got a respite. You shifted your nervous system gear for a minute, and now you get back on. And by the end of the day, you're really only jumping up to here. So you can have a slow, controlled landing into bed. Your cortisol has been attended to. Your nervous system has been attended to. And we start to shift the cycle of our orientation in our environment. I like to tell people, if you're in the sympathetic tone all of the time, you're running on diesel. So something to keep in mind is a top-down, bottom-up approach. Everything I'm asking you to do is this bottom-up, right? You need to breathe, you need to reorient, you need to get into your childhood trauma, you need to heal, you need to, reappraise. The top-down approach would be, if you're running on diesel, we better give you diesel. And most of you who are running on diesel are only getting unleaded. And how do we support that? That's where the medicinary part comes in. I'm not going to give medical advice here, whether it's adrenal support, whether it's counseling, whether it's medications, changing the environment. I have one patient who's in such an abusive relationship that I know, and he knows, until he's no longer in that relationship, he's never not going to be in go mode. He's never going to feel safe at home. And so what do? We give him diesel. Continue to counsel, aware. This is where you're going to be, and it's not sustainable. But healing also is not necessarily possible if you're giving unleaded to somebody who's operating on diesel. And now I'm going to ask you to do one more thing with your time and energy in an effort to heal. So it's a really delicate balance there, but an important one to make. So how does this all tie into cognition? I've kind of made a few points about that, but I want to recap. Adverse childhood experiences are emotionally salient memories. I've had trauma in a time in my life where I wasn't fully neurodevelopmental. So as I was processing or consolidating that memory, it went to my amygdalar filing cabinet instead of the one that I can recall. And as those pile up, those overlays of panoramas continue to pile up, my neuroception becomes saturated with threat. And when it's saturated with threat, I have a hard time responding appropriately to these threats. One, because I probably don't know what they are. And two, because my interoception now, my vagal nerve activity, is interrupted because of my nervous system tone, my hyperventilation, my physiologic state. So now everything really is threat and danger. So I continue to be in the sympathetic nervous system state. And then somebody says, "What'd you have for breakfast yesterday? Why did I come in this room? Oh my gosh, what are my grandchildren's name? When did 9/11 happen?" Fun fact for all of you, is the most commonly failed question in my practice. Here's my theory. Here's my hypothesis. I'll use a scientifically accurate word. Here's my hypothesis. The majority of my patients are over 70 years old. 9/11 was 22 years ago. Where are we in our late 40s, early 50s? We in the hustle, right? We are working hard. We're providing for a family. We're in a relationship. We're in the prime of our life, in the most active time of our life. And boom, something traumatic happens. And we're supposed to remember the logistics and the logic and the time and the date of something that emotionally impacted us at such a deep core level that the amygdala memory is going to come up, right? I ask people about 9/11 all the time in my practice. Oh my gosh, I remember the scenes. I remember the people. I remember the smell for people who were there. I remember these things. I remember my mom crying. I remember all of it. I remember where I was, right? Yeah, what year was it? Tell me. Jackie, what year was 9/11? Most common answer? 1995. 2010. I mean, I get all across the board. And it's the most poignant example to me when I hear somebody say that answer. Do you think I'm going, oh my gosh, you have cognitive impairment and your memory is failing? Or do I think, oh my gosh, your amygdala is so overactivated with that memory, and now you're coming in here saying, I'm an anxious person, by nature of not remembering, we're going to be scared. Oh my gosh, maybe I'm not remembering. I remember my grandpa had Alzheimer's and I saw what that looked like and he had to be in a home and it was awful. And oh my gosh, I don't want that. Maybe I can't, maybe I have memory, right? Now we're going full amygdala mode of the fear of not remembering. So we're perpetuating the cycle, and God knows you're never going to remember anything in that state. So is this to say that cognitive impairment doesn't exist? No. I have a heartbreaking job. I have to diagnose this. We have to treat it. We have to support both the person and the caregiver. Is it to say that I would guess at least 50% of my patients who've been diagnosed with mild cognitive impairment has some sort of adverse childhood event that I know and recognize is affecting their ability to recall, declarative memory, working memory? 100%. And this just isn't anecdotal. I use a program called the Crayo's Brain Science. I do a subjective and objective questionnaire every 3 months to assess how is your mood, how is your anxiety, how is your depression, how is your perceived stress, what is your PTSD score? Are you attention deficit? What is your attention capabilities? Have you had a traumatic brain injury or concussion? Can we do a questionnaire about that? Do you have headaches? Do you have light sensitivity? Do you have tinnitus? Is there inflammation in your brain? So we do all these questionnaires and then we play a bunch of games. That secondary to a full 3-hour neuropsych eval is the next most accurate way to assess the brain. I always say it's like a lab order for your brain. What are the values? How is your brain operating now? And I have the trends to show it. The people who do the work, the people who help their adrenals, the people who go to counseling, the people who do the breath work, the people who reappraise and recognize that as much as we want to logic and reason our way out of our childhood, it does not equate forgiving what happened in our childhood. That's different. Recognizing that it's there without logic and reasoning your way out of it is giving yourself the opportunity to actually heal and understand how you orient, which then can shift how you perceive stress, which then can lower your anxiety, which then will lower your amygdala activity and allow you to stimulate your hippocampus, which in all of the studies are showing to enhance memory function. It's not easy. It's got a lifetime of work. It's never going to be over. And it's important. And it's what I see and continue to see as the missing link in the Dale Bredesen protocol in memory care facilities is, are we talking about adverse childhood experiences? And how did you orient to the world when you were learning how to orient? Not how do you now, because you don't know how to orient to safety if you've never been taught it as your brain was developing. Kind of the crux of what I wanted to talk about today. We have 5 minutes left in the lecture. If anybody has questions, concerns, I want you to feel free to reach out to me at the clinic, info@CDA Healing Arts. You can send me a message. If you want resources, if you want to take the quiz, whatever that looks like, definitely feel free to reach out and stay in touch. This is going to be recorded. So what I'm going to do is I'm going to stop the recording here. So if anybody does have questions that they don't want to be shared publicly, I will do that now.